Welcome to AETCM, the Emergency Medicine Channel. So, shall we start? We received a 56-year-old male to the ER with complaints of vertigo, complaints of the dizziness, and 2 episodes of vomiting. So, in the triage area was taken the respiratory rate of 18 and blood pressure of 120 by 80 and GCS of full 15. So this the triad SARS score was more than 12. So it was considered to be in green area. We had taken the patient into green area in the emergency room. Coming now to the primary survey. Primary survey, airway was patent. Patient was talking in one full sentence. Next, breathing wise, patient is having respiratory rate of 18 per minute and saturation of 100% at room air. Bilateral air entry was equal. Coming to the circulation, BP was 120 by 80 and pulse rate was 76 per minute. And peripheral pulses are palpable.
CRT?
CRT less than 2 seconds. Good capillary refill time. And then coming to disability, patient has GCS of E4, V5, M6 and pupils are bilaterally reactive to light. Coming to exposure, patient was having normal temperature is febrile and GRBS was 130 mg per dl. So after completing primary survey was clear. So coming to the secondary survey.
So the complaint is vertigo,
dizziness.
Dizziness and?
The initial saying of the patient was dizziness and 2 episodes of vomiting.
So you did your primary survey.
Primary survey
make
was
sure
clean.
that everything is fine. She is like
Yes, sir.
stable enough, and then you are moving on to the secondary survey. Okay.
In secondary survey, the starting with the history, comorbidities, no any known comorbidities. Patient is not
The ample history.
Ample history. No allergy to any medication. And next, not on any medications presently. No any past illnesses as such. And the last meal has taken in the...
What all medications you are specifically?
We have to look out, in this case, ideally...
Dizziness and all.
In dizziness and all, we have to see if he's any cardiac history, is there cardiac any conditions, is taking any medication or any neurological medications, he's on any medication. Apart from that, many antibiotics can have side effects.
What antibiotic?
Like aminoglycosides can have ototoxicity and cause vertigo.
Vertigo and all. Till now, it's not sure whether it's dizziness or this thing.
So now starting with the actual history.
Okay.
So on asking the patient, like a patient complains that he is having a feeling of the rotation of the room. So this can be this differentiation from dizziness can be made that he's having not a syncope-like condition but a vertigo-like condition, and he has this vertigo-like feeling only when there is a positional variation. When he's getting up from the bed or is sitting down, lying down, then only he's having this.
So this being a vertigo case, you're supposed to go ahead with the OD para approach, no?
Yes.
It's not Socrates.
So
It's the onset, duration, intensity, progression, previous episodes, at the aggravating factor, relieving factor, then associated symptoms.
Regarding the OD para approach for vertigo, onset was today morning at 10 o'clock onwards. It was since the last 4 hours.
In any case of vertigo, what are the DDs that you should consider in the ED?
In vertigo, DDs can be like a peripheral pathology or a central pathology. In most common DD would be the BP, benign paroxysmal positional vertigo, BPPV.
Most common. Okay.
Most common in the EDs, but most important to rule out in the ED would be a posterior cerebellar stroke. We can differentiate this pathological causes as central or peripheral. In peripheral, it can be vestibular neuritis or labyrinthitis or Meniere's disease. And BPPV.
With and without hearing loss.
With hearing loss, it would be Meniere's labyrinthitis, and any osteomastoiditis, any infections of the ear, CSOM, ASOM, such conditions. Without would be like having vestibular schwannoma.
So you go ahead with your HOPC. Yes. After that, we'll come to the point. Okay.
So the onset had been within the last 4 hours. It has started this vertigo-like sensation.
What was he doing at that point of time?
He just had his breakfast and he was lying down with it.
Breakfast and lying down.
He went to lie down after breakfast.
Okay.
At that time, he
So
developed.
it happened in the lying down.
When he was about to lie down.
When he is about to lie down.
Once he going to lie, when he lied down, he felt the vertigo again. When he got up again, he felt it. So
Okay, when he lied down, he felt vertigo, and when he got up, also he got
vertigo.
vertigo. Okay, so what did he do? Like,
He lied down as he was feeling the dizziness when he was lying down. He stared.
so sudden onset.
Sudden onset.
4 hours back.
4 hours back, sudden onset. Duration was for the 20-30 seconds. When there is any variation, then he is having these vertigo episodes.
So on and off.
On and off. On and off kind of thing.
Less than 30 seconds.
Lasting less than 30 seconds.
Okay. Varying with posture.
Varying with the postural variation, varying with the posture. Aggravating factors would be the varying with the posture, and relieving factors are when he is lying down and taking rest for some time, it is automatically resolving by itself. Associated with 2 episodes of vomiting. When he had this vertigo and this feeling, he had vomited twice till now, and vomiting consists of only food particles, no any blood or anything.
The intensity, it's affecting activities of daily living.
Yes,
He's not unable to get up
and do his regular activity right now.
So you addressed everything: the onset, duration, intensity, progression. Is it like similar, like till
This
now?
has been just only for 4 hours.
4 hours. Still now, like when the patient came to ER, also the same complaint.
Same
On and
complaints,
off,
yeah.
lasting less than 10 seconds. Okay. Now the associated symptoms. No, was it did the symptoms precipitate on looking towards the left side or right side? Anything of that sort?
Nothing of that sort was noted by the patient until now, whether which side he is having any preferential increase.
Okay. So then associated symptoms.
Associated symptoms, vomiting.
Okay. Being vertigo, you'll have to first of all address CNS, then CVS, then
CVS,
ENT
CNS and ear examination.
Okay, so no heart, any chest pain,
No
any
previous
palpitation.
comorbidity, no any history of any chest pain, palpitation or any previous histories of heart complaints also. And regarding the CNS component,
Because this is important because vertigo should differentiate from pre-syncope. Or that is pre-syncope is usually associated with the cardiac
cause.
problem, some arrhythmias. Maybe like some aortic stenosis, aortic sclerosis. Maybe we'll have hypertrophic cardiomyopathy. Okay, and also sudden cardiac death and some brigadas, something of that sort may be there. Arrhythmias, SVT, unstable tachyarrhythmias, even narrow or broad. So that is important.
Then CNS,
So
if
no
there
chest pain, no palpitation. Okay. Respiratory, serious RS. No shortness of breath, no cough, no wheezing, nothing. All right. Then CNS.
CNS, if there is any facial asymmetry or any reduced sensation of the face, any cranial nerve involvements.
Why cranial nerve is because vertigo case, if it's cranial nerve is involved, which cranial nerve will be involved?
5th, 7th.
5 and 7. Okay. So what are you basically suspecting?
Vestibular schwannoma.
Okay.
So the tumor on the CP angle, anything compressing
CP angle
the
tumor and all may compress and may cause
cranial nerve
cranial
palsy.
trigeminal means what all? Which nerve?
Ophthalmic,
maxillary, mandibular, the trigeminal.
sensory.
Right?
Yes.
Okay. So you'll have to do the sense. All clinical examination relevant. The cranial nerve examination has to be done properly in any case of vertigo. And also specifically for you're looking for the posterior circulation stroke. No?
So any weaknesses, focal neural deficits.
That will come on to while examination will deal. So CNS examination, any decreased sensorium, nothing. No headache.
No head.
No headache. Vertigo is there. Any vision problem?
No vision problem, no any nystagmus, any side movement having a problem.
The nystagmus and all you're not supposed to mention here. Because you're still in your
History.
HOPC. Nystagmus is a clinical sign which you elicit in your clinical examination. History part you're not supposed to say no nystagmus and stuff like that.
Yes.
Okay. Then no seizure.
No seizure, no any weakness of
No
any
neck
kind.
stiffness.
No next.
Okay. No. Okay. Any CNS, CVS over
Then ear specific.
RS
Any
over.
ear discharge.
Musculoskeletal, any problem? Any weakness, body pain, paralysis, any weakness? No. No deficits.
No deficits.
Nothing is there. Okay. Then to add on, we can just add on like no skin changes. Maybe like it's not relevant in this. Only thing is relevant skin changes we can expect is this thing. The Ramsay Hunt syndrome, herpes. If there are any lesions on the ear area, okay, which may suggest a this thing, herpes infection. Then any loss of weight, loss of appetite,
No loss of.
lumps or bumps in the body, nothing, no. Any tumor and all, you're suspecting.
Loss of weight can be there, but no loss of weight.
Okay, GIT, genitourinary, no issues.
No.
Okay, so that is least relevant in the case of a vertigo. GIT, genitourinary and things. Or else one thing can happen is patient is having pre-syncope secondary to massive fluid loss and gastroenteritis.
Okay.
If it's dehydrated and all, the patient may have. We can ask whether loose stools is there or not if you're suspecting a pre-syncope. But here, according to your history, you are very sure that it is vertigo.
Yes.
And it's from the history itself, it's quite evident that it's a peripheral vertigo. Looks more like a BPP wave.
Yes.
Okay. But nothing else fits into your
D differential.
DDs. Okay.
Then next coming to the examination.
Past medical history.
No past medical history, no any known comorbidities.
Okay. So what all things you are interested in? Vertigo.
Past history is any
dizziness case. What all things you are interested? Any cardiac, any problem, any neurological problem?
syncope evaluation also should be considered in
That
dizziness.
should be considered because at times you may get even if the history is right, suggests towards this thing, about a BPPV. At times when you take an ECG, you may get all of a sudden you may get some heart block or something. You won't know. Okay, but your heart rate is all perfectly fine. 60s or something, 76. Very unlikely to be a cardiac. Oh, okay. So past medical history, nothing. Past surgical history,
Nothing.
Family history, sudden cardiac death or anything. Nothing.
Nothing.
Because Brugada and all may happen. Okay. Patient had no fever also, right?
Patient has no fever right now.
Okay. Some inflammation, infection and all can cause. Then
Examination.
things almost sexual history and all, that's fine, no?
No sexual history.
Okay. Not on Viagra and things, none.
No, sir.
Okay. What is he doing? What is his job?
IT professional.
Okay. Examination. So your HOP is this. Your this thing is over.
Yes. History
is over.
Yes. Now coming to the examination component.
Okay.
In the examination.
So ideally, like any, if you are planning to write the MRCOM OSCE, any patient coming with dizziness or syncope or vertigo, anything of that sort, should move to the resuscitation room, and then check all the vital signs. Make sure vital signs are fine, and then give the appropriate medications to control the symptoms. Make the patient comfortable. Then only you're supposed to go ahead with the second the exam, the ample history, and all this examination and all. That's according to the MRCOM OSCE, this thing. But practically speaking, that will be a problem because if it is a vertigo case and straight away you give some Stemetil or something, injection IM, what happens is further examination findings will be affected. If you're doing a Dixolpike test or even if you're doing a Epley's manure, nystagmus, everything will be affected. So practically speaking, that's a problem. But if you're planning to write the MRCOM OSCE, you'll have to say that I'll give you medicines for so and so for vertigo, this thing. So are you comfortable now? Yes. If once the patient says I'm comfortable, then you go ahead and move with the ample history and this thing. Okay. That's for examination purpose only. All right.
Then now coming to the examination component. Examination like specific examination for.
You're basically interested in CVS, CNS and ENT examination.
Yes, but okay, CVS examination we start with to rule out syncope like condition. CVS the examination like patient
Vitals are all stable. No heart rate, BP, CRT,
Everything is stable.
Okay.
Auscultating sounds are only S1, S2.
No. Inspection, palpation, percussion. Like that, you'll have to go systematically.
Yes. Inspection.
Just like you do in your MBBS examination, inspection, what all things. Okay. Probably that is normal in this case.
Yes, sir.
Serious part is normal.
Normal.
No atrial fibrillation, no arrhythmias, not suspecting anything. Murmurs S1, S2 is present. No murmurs, nothing. No.
JVP raise.
What murmur you will get in AS? Atrial aortic stenosis.
Francis.
Ejection systolic, no?
Ejection.
Fan systolic is in
AST.
MR, right?
MR.
MS? Mid-diastolic murmur, no?
Mid-diastolic.
Okay. All right. So what about the ECG? ECG would have been taken by this time, no?
Adjunctive. ECG is normal sinus rhythm, 76 heart rate.
96 heart rate. Okay. No LVH.
No,
No
sir.
STT changes. Okay. Okay. What are you specifically interested in? ECG.
ECG to see if there is any arrhythmia,
All arrhythmias, Bugardas,
any Brugada.
underlying WPW, delta wave patterns, short PR interval, features of WPW or Brugada or even these arrhythmias.
Yes.
Okay. Why arrhythmia is important? Because suppose the patient is having a stroke, is suspecting a stroke, that becomes a cardioembolic. Or if then AF is there, suppose, and if there is a clot in the left atrium, it can
Get
go away
dislodged the
and get
clot to
dislodged and it can cause a
stroke.
post-circulation stroke. So that is important then. Then inspection, palpation, percussion, auscultation, everything is over.
Then CNS exam.
CNS examination, yeah. CNS, what all things?
First, like
CNS basically you are basically interested in to know whether it's a posterior circulation stroke or not.
yes. Central component
Central
is
component
involved.
is involved, or if there is some tumor,
Cerebrofrontal areas that
CP
also other cranial nerves can be
CP angle
affected.
tumors are there or not, an acoustic neuroma is there or not.
Yes.
So these are your basic priorities. Because posterior circulation stroke we'll have to identify early, because within
Window period
within the window period 3.5 hours we'll have to thrombolize. So many times what happens is people may treat a vertigo with a stem metal or this thing and may even discharge even without doing the
Further workup.
MRI stroke protocol or anything. For the workup they may discharge, and those things you'll have to address by testing for the cerebellar signs. Okay, so CNS examination, what all things?
CNS examination, like initially we can test the power, tone, of all the
Bulk, tone,
four
power, reflexes. Okay, sensory, motor, cerebellar signs,
cerebellar signs we can finger,
high mental
nose
functions.
test.
First of all, high mental functions.
First, yes.
This fully conscious.
Fully
oriented,
conscious
people are
oriented.
equal reacting. Okay.
After higher
Bulk,
mental,
tone, power, reflexes, everything is
normal, fine. Normal movement, normal.
sensory. This part and all, everything is clear.
Everything is clear. Yes.
Trigeminal area, facial,
It's clear.
trigeminal power. How will you assess power of the trigeminal nerve?
By clenching.
It move like this. Okay. Fifth nerve, right?
Fifth, yes.
Okay. One thing which I forgot to mention in the history is whether in HOPC, the ear examination, you'll have to ask specifically whether there is any tinnitus.
Okay, tinnitus.
Ear discharge, ear tinnitus, any skin lesions I've already mentioned. ENT you'll have to focus, which I forgot to mention that. Okay. Then
Examination wise, any weakness, this power, tone, bulk of this individual, then coming to cranial nerve, all the 12 cranial nerve examinations to be done to see if there is any weakness. And then coming to the
even this cranial nerve examination may come as a question for your OSCE. Within 7 minutes, you'll have to do all the 12 cranial nerves examination. Okay. So you'll have to be very organized and systematic. Okay, that we'll deal in some other class. Okay.
The next ENT examination we have to go through using otoscope to see if there is any perforation or any discharge.
Same thing,
issue.
like not even auto inspection, but
Inspection.
like from external onwards, you'll have to inspection.
Yes. If there is any
Otoscope, auditory canal, meatus, everything, auditory meatus, everything we'll have to check, including the tympanic membrane for any rupture or any secretions. Okay.
then like specifically
Then Rene test, Weber test.
test for the hearing, whether sensorineural or conductive hearing.
We're interested to know whether there is a hearing loss or whether there is no hearing loss. Okay. Ideally, how is it Rene and Weber?
Sure.
Ideally, how is Weber performed?
Weber is performed after striking this to the chin head of the hand. We put it on the base of the prongs.
What hertz of the 512 hertz?
512 hertz.
You put it here, and see, ideally it should be
equally audible for both the sides. Rene test would be used like
if
comparing.
there is abnormal, that will be, if it is unilateral, means it's a conductive hearing loss. What about Rene?
Rene, we asked to, after striking the tuning fork, we put it to the patient's ear, and then when he says it stopped, when we put it over here and we see whether it's.
So air conduction more than bone conduction, in the normal. Rene, right? Okay. So
then like specific to the vertigo tests which we do, examination tests. Initially, if the patient is having a short acting like vertigo, short paroxysmal vertigos, then we should not do hints.
So what is hints examination?
Hints is HI is for head impulse, N is nystagmus, TS is tilt skew. Test of skew.
Head impulse, nystagmus, and test of skew. And this is not applied in BPPV at all.
This is applied only for a continuous case of vertigo associated with a nystagmus of specific gaze or any gaze nystagmus or specific eye movement nystagmus.
Basically, you are interested to know whether it's vestibular neuritis or some central cause of
central cause of the vertigo. In that case, it's only hints test should be.
Okay.
If it is a paroxysmal kind of a test, first approach should be to rule out BPPV.
Yes.
In BPPV, to rule out BPPV, first test we can do is Dix-Hallpike test. This Dix-Hallpike test is usually
so basically for diagnosing the BPPV, you do the Dix-Hallpike test. For the treatment part, you do the Epley's maneuver.
These both
Dix-Hallpike. So even for MCQs, that they can confuse you.
Okay.
So it's a common question in a Markham SBA and all. What test? Like at times people may confuse with Dix-Hallpike and Epley's. Epley's is the maneuver. Dix-Hallpike is the test that the patient will be asked to sit like that and turn the head towards the 45 degrees, and immediately patient will be lied down
on this table,
on the edge of the table, so that the head will be extended by around 20 to 30 degrees, and then you look for nystagmus. Okay. So nystagmus till the fast component towards the affected part, no?
Yes.
Okay. Then that is called Dix-Hallpike test. Once
it is positive, then we have to do the Epley's maneuver.
Okay, the semicircular canal is affected. That part is affected. Okay. That is the meaning. Once it is positive, you have confirmed your diagnosis. Then you will be doing your Epley's maneuver. How it is done?
The first step, as in the Dix-Hallpike test, that would be only the first stage of Epley's maneuver. After lying towards the affected side, we shift the head to the unaffected side, 90 degrees.
Once nystagmus is settled,
30 seconds after it is settled,
45 degrees turned, lie down. Once nystagmus is settled, turn the head 45 degrees. Then
again wait for 30 seconds.
Then
ask them to rotate his body, the shoulders, and then the face again rotates.
To 90 degrees. 90 degree body rotation towards the other side. Then again wait for 30 seconds.
Then ask him supine.
Then you make him
sitting position.
Sitting. Okay, this can be repeated minimum
2 times.
Two times is what in some books they say 2 times. Beyond that, you don't repeat it. You just give some vestibular sedatives and that's the plan.
Yes. Okay. Once this Epley's maneuver is done, we expect that the BPPV is settled, and again we can do a Dix-Hallpike test to check if the nystagmus is still present or not.
Okay. So for this patient, that was done.
Yes. Right-sided, he was having the positional test positive.
Right side positional test positive. Okay.
Dix-Hallpike test was positive. So once Epley's maneuver was done, it got corrected itself.
So finally, he was discharged with
Suppressant.
suppressants. What all things?
We can give chlormethazine, promethazine, antihistaminics and anticholinergic antiemetics in that class of drugs we can give. So,
Okay, and I was asked to review in ENT OPD after
1 week because this medications will suppress it till 1 week. We cannot again retest his.
Okay. We were always also talking about some hints test. What is hints test?
Hints test is to differentiate between peripheral and central vertigo in case of a continuous gradual vertigo which developed in the patient and he's having nystagmus. The components would be first head impulse test. We ask the patient to focus on the examiner's face and we rotate the face of the patient 20 to 40 degrees abruptly.
Okay, like this. Abruptly, you'll
Abruptly without his
rotating.
knowing which side we are going to rotate and fix it.
You will just hold it like this and then slowly, suddenly you move it. And you see for
the eye whether it is having a nystagmus movement, saccade, was there any saccade movement,
correct saccades is there or not.
or is able to focus on the examiner. If it is a central cause, he'll be able to, if it's a normal patient, he'll be able to focus the central. If there's a peripheral cause of vertigo, then he cannot focus on the examiner's face, it will have a saccade, he will correct and it will come back to the face. So that would suggest that it's a peripheral cause of vertigo.
Corrective saccade suggest?
Peripheral cause of vertigo.
If there is no saccade,
There is no saccade, it can be central or it's
either
normal.
it can be a normal patient or it could be a central problem. So that is problematic. So if there is no corrective saccade, it is problematic. Either problematic or it is normal.
Normal.
Okay.
Then next nystagmus.
That is head impulse. Then nystagmus. Okay.
Nystagmus we can differentiate between central and peripheral. Like peripheral would be unidirectional kind of a nystagmus, whereas central can be bidirectional nystagmus. And in
how do you really assess? You can keep a paper here. Ask them to look on towards the left side, as if he's looking on the wall, and then look for the nystagmus. Okay.
The fast component would indicate the direction in the peripheral causes. Fast component would indicate the direction of the
So there is nystagmus. There is a slow component as well as a fast component. We are basically looking for the fast component.
Which side? The direction of the fast
corrective component. That's called a saccade.
Yes. Peripheral peripheral cause of vertigo will be having the fast component the same direction of the problem, and when you ask him to look at the same side, it will even increase the nystagmus also. It will potentiate.
Okay. So bidirectional nystagmus means it's problematic.
Central. It
But
can be even rotatory also. And
can be rotatory nystagmus also. So problematic. Okay. So absence of head impulse test, bidirectional nystagmus, then will be problematic. Okay. Then test of skew.
Test of skew. In test of skew, it's same like the cover uncover test, where we use the cover and we do the cover uncover test when we uncover the
cover and. Okay, you cover it and then uncover.
We cover it and fix it on one object, and when we uncover it, if both the eyes are at
normally
different levels.
it should be in the level straight. What happens is if you uncover it, all of a sudden it try to go upwards. Okay, so that is suggests more of a central
cause. These three can be done to differentiate between peripheral and central cause of vertigo.
For the central cause, you'll have to go do imaging, the MRI brain with contrast.
Admission
is warranted.
Peripheral causes, it can be vestibular neuritis, which is like most like.
But you're not supposed to do hints in BPPV and all.
Yes.
Okay.
It won't be possible.
It's not for posterior circulation stroke also. That is to be understood. So for injection, what was given for him as injection? Stomatal.
Injection as such, we had given only antiemetics because he had vomited 2 times post vertigo episode. So only injection ondansetron was given 4 mg, and that's the only injection given. But tablet wise was given for his suppression of the vestibular apparatus.
Okay. Other systems are all fine.
Yes.
Okay. Anything more to add on?